If a surgeon takes like 25 centimeters of bone out of your leg, bends it in half, and then literally sews it into your face, does your leg still work?
Yeah, it's a terrifying question.
It really is. Well, welcome to another deep dive. Usually when we look at medical records for you, there's this expectation of like intense clinical detachment. You picture a printed chart, neat rows of data, blood pressure, heart rate.
Right, very sterile.
Exactly, very sterile. But the stack of sources we are looking at today is completely different. We have this dense, honestly fascinating collection of handwritten clinical notes, surgery protocols, oncology diagrams, histopathology charts.
Yeah, it definitely doesn't look like a standard hospital chart.
Not at all. It reads more like a battle commander's field journal.
It really does. It is essentially a high-stakes playbook for some of the most complex real estate in the human body. The battlefield here is the oral cavity, the larynx, and the actual mechanics of head and neck reconstruction.
Right.
Because every single millimeter matters when you are dealing with a person's ability to speak, to breathe, to eat. The margins for error are just vanishingly small, and the consequences are immediate.
So today, our mission is to decode this playbook. We're going to track the entire life cycle of head and neck cancer, from the exact moment a single microscopic cell goes rogue, to how surgeons track its movement, how they eradicate it, and ultimately, how they pull off these absolute architectural miracles to rebuild a human jaw.
It's a huge journey.
It is. Okay, let's unpack this, because before we get to the wild surgeries, we have to understand how the disease actually starts. Looking at the histopathology notes, it seems like these cells don't just, multiply.
Yeah.
They completely abandon their original identity.
Yeah, that's exactly what happens. Under a microscope, the tissue loses all of its normal, organized architecture. The notes specifically emphasize this term, pleomorphism.
Pleomorphism.
Right, yeah. In a healthy state, your cells have a very predictable, uniform shape that's based on their specific function. But pleomorphism means that the genetic blueprint has become so corrupted that the cells just start mutating into these chaotic, unpredictable shapes and sizes.
Wow.
And you also see a massive spike in what they call mitotic figures.
Which means they're dividing, right?
Exactly. The physical process of cellular division is just happening at a highly aggressive, completely abnormal rate.
Which brings us to a detail in the notes that sounds almost, bizarre out of context. They call them keratin pearls.
Right, the keratin pearls.
Because we know normal skin cells produce keratin for protection, right? Like hair and nails. But here, the notes indicate that the cancer cells get so confused that they just ball the keratin up into these strange little pearl-like structures buried deep down in the tissue.
And that is actually the defining signature of squamous cell carcinoma.
Really?
Yeah. Squamous cells are the flat cells that line the surface of your mouth and throat. And normally, they shed and produce keratin to create a protective barrier.
Okay, that makes sense.
But when they become cancerous and start invading deeper into the underlying tissue, they are still blindly following that old programming. They just keep churning out keratin.
But they're underground now.
Exactly. Because they are trapped underground, so to speak, the keratin has absolutely nowhere to go. It just compacts into these dense circular layers.
It's like a factory whose delivery doors have been entirely bricked up, but the machines are just still running at maximum speed.
That is a perfect way to picture it.
And what breaks the machines in the first place? The notes list a pretty wide range of risk factors. You have the localized addictions, which are heavily prevalent in certain parts of the world. Things like smokeless tobacco, chewable tobacco, pan, hookahs, nasal.
Yes, the chemical carcinogens.
But the viral component is what really stood out to me. The human papillomavirus, specifically strains 16 and 18.
Right, because viral-driven head and neck cancers behave entirely differently than tobacco-driven ones. And the notes actually specify that HPV-18 is particularly notorious.
Right, yeah. They note HPV-18 is actually the more lethal of the two, causing these things called cystic nodes and presenting with multiple lesions. But wait, why does a virus cause cysts instead of solid tumors?
Well, the virus fundamentally alters the cellular machinery. It drives extreme fluid secretion and rapid cellular breakdown right within the lymph nodes.
Oh, wow.
Yeah. So instead of forming a hard, solid mass of tumor cells, the cancer basically hollows out and creates these fluid-filled cystic cavities.
Which has to be harder to see.
Exactly. It makes them notoriously tricky to identify on scans, and they are incredibly aggressive in how they spread.
But speaking of the body's defense against that spread, I ran into a detail about tumor immunity that just completely threw me.
Oh, the age factor.
Yeah. We usually assume a young, healthy person is going to have the most robust immune response to any threat. But the notes say tumor immunity is actually decreased in young patients and increased in adult patients. How is that even possible?
It's super counterintuitive, but it requires looking at exactly which weapons the immune system uses against tumors. The notes point to a higher number of natural killer cells, or NK cells, in older adults.
Okay, NK cells.
Right. NK cells are basically specialized assassins. They don't just attack any random foreign body, they specifically hunt for cells that have turned cancerous.
Oh, I see.
So, while a young person has a really strong general immunity for colds and infections, an adult has spent decades accumulating immune experience. Their NK cell population has matured and expanded over all that time.
So they just have a bigger specialized army.
Exactly. Counterintuitively, older patients possess a larger arsenal of the exact cellular weapon needed to fight back against a tumor.
That is wild, which honestly makes the concept of field cancerization even more daunting to me.
Right.
Reading the notes on this, I just kept picturing a lawn full of weed seeds. If you have a yard completely saturated with seeds, pulling up the one visible weed that finally sprouted doesn't mean your lawn is safe.
Not at all.
You've removed the obvious problem, sure, but the soil itself is totally compromised. So if a surgeon takes out a tumor and gets perfectly clear margins, doesn't field cancerization mean the entire mouth is still just a ticking time bomb?
What's fascinating here is that the cellular reality is actually far more aggressive than just dormant seeds in a lawn.
Really?
Yeah. Field cancerization means the entire mucosal lining of the mouth and throat has been continuously bathed in the exact same carcinogens, whether that's tobacco juice or a high viral load.
Right, it all got exposed.
Exactly. So even if the visible tumor is removed, the surrounding tissue that looks perfectly normal to the naked eye, it is not normal. The genetic damage has already occurred.
Oh, man.
There is heightened mitotic activity, meaning cells are actively preparing to divide dangerously across the whole mucosal field. So the risk of a secondary, completely new cancer forming right adjacent to the original surgical site remains exceptionally high.
Because that entire field is just highly unstable. And because it's so unstable, the cancer doesn't stay contained for long. The high cellular turnover practically forces those rogue cells to spill over into the body's drainage system, which transitions us straight into how doctors actually track the enemy. Phase 2, the lymphatic system.
Right, the body's internal plumbing. The lymphatic system acts as a fluid return network, draining waste and immune cells from the tissues. But a malignant tumor essentially hijacks the system.
It uses it like a highway.
Yeah, it uses it as a high-speed transit network to spread to the rest of the body.
I looked at lymph nodes like a series of security checkpoints along that highway. The cancer gets on the highway, and the surgical teams have to figure out exactly which checkpoints have been overrun, and they aren't just looking for a generic bump on a CT scan. The clinical notes outline this rigorously strict diagnostic criteria for identifying a metastatic lymph node.
The parameters are extremely strict. First, the size, right? A node larger than 1 centimeter raises immediate suspicion. But the architecture of the node is even more telling. A healthy lymph node is ovoid. It's shaped somewhat like a kidney bean.
Right.
But when it becomes packed with multiplying cancer cells, it completely loses loses that shape. It balloons out and becomes perfectly spherical.
And then the notes mention two other things: peripheral rim enhancement and central necrosis. Now, central necrosis just sounds like a deeply grim biological event.
It is. The mechanism behind it is absolutely brutal. As the tumor takes over this tiny lymph node, it multiplies at such a frantic pace that it outstrips its own blood supply.
Oh, it grows too fast for its own good.
Exactly. The cells on the outer edge of the node steal all the oxygen and all the nutrients. Consequently, the cancer cells trapped in the very center suffocate and die en masse. They literally turn into a pocket of liquid dead tissue.
Gross.
Yeah, that is central necrosis. So on a CT scan, with contrast, the active blood-hungry rim enhancement, while that dead center registers as just a dark, empty void.
You were literally looking at the blast crater of the cancer right there on the scan.
Exactly.
But as we track how this cancer moves, we have to talk about submucous fibrosis, or SMF.
Sure.
For you listening, SMF is a severe chronic condition often caused by chewing hookah or pan. It basically creates this incredibly thick, rigid scarring inside the mouth to the point where patients can barely even open their jaws. It's devastating.
It really is.
Yet, the notes reveal this wild, counterintuitive twist. If a patient has SMF, their chance of the cancer spreading the metastasis actually decreases.
Wait, so the severe scarring essentially acts like a physical roadblock that traps the cancer in place.
If we connect this to the bigger picture, it is one of the strangest defensive ironies in human biology.
Yeah.
The constant irritation from the chew has damaged the tissue so severely that it forms these dense fibrous bands of scar tissue.
Right.
And this fibrosis is so thick that it physically crushes and obliterates the microscopic lymphatic channels, the highway you mentioned earlier. It's effectively demolished. The cancer has nowhere to drain. Wow. But the notes also mention a chemical shift happening there too, not just a physical one.
Yes, the chronic inflammatory state of SMF fundamentally alters the tumor's microenvironment. It suppresses interleukin-6, or IL-6, which is a signaling protein that typically acts like a fertilizer promoting tumor growth and blood vessel formation.
Okay, so it cuts off the fertilizer.
Exactly. And simultaneously, it increases levels of interleukin-8. In this specific, highly fibrotic context, the IL-8 acts as an anti-cancerous agent, recruiting immune cells that further box the tumor in. So the body's own damage accidentally constructs both a physical and chemical fortress around the cancer.
It's staggering, but obviously, even if it's trapped, the tumor is still extremely active and dangerous.
Very much so.
Once the medical team has mapped these checkpoints, they have to move in and neutralize the threat. Looking at the notes for phase 3, the arsenal they deploy is heavy. The two main avenues of attack are radiation therapy and transoral laser microsurgery.
Right. Starting with radiation therapy, or RT. The fundamental goal there is destruction at the genetic level. High-energy beams are targeted at the tumor to physically shadow the DNA double helix of the cancer cells.
Which stops them from dividing.
Precisely. It ensures they can no longer replicate, which eventually forces the tumor to shrink and die.
We know radiation is harsh, but the collateral damage detailed in these clinical notes is immense. The short-term effects include severe mucositis, which is painful inflammation of the digestive tract lining, and complete taste disturbance.
Yeah, it's very tough on the patient.
But the long-term effects are just devastating. The notes list xerostomia, which is a permanent severe dry mouth because the radiation irreparably destroys the salivary glands, and then there's osteoradionecrosis, literally bone death.
Osteoradionecrosis is absolutely one of the most feared complications, because the radiation doesn't just damage the cancer, it scorches the tiny, delicate blood vessels that feed the jawbone itself.
Oh, wow.
Yeah. Over the course of years, the bone tissue is chronically starved of oxygen and nutrients until it literally dies and begins to crumble inside the body.
That sounds horrific. To avoid that kind of collateral damage, the notes do outline alternatives, including cyberknife radiation and brachytherapy.
Right, CyberKnife is a fascinating piece of technology. It is essentially a robotic arm that delivers highly focused beams of radiation from hundreds of different angles.
So no single beam is too strong.
Exactly. None of the individual beams are strong enough to damage the healthy tissue they pass through, but they all converge perfectly on the tumor, delivering a lethal dose exactly where it's needed while sparing the jawbone.
And then brachytherapy.
Brachytherapy takes a different approach by planting radioactive seeds, usually things like iridium-192 or gold-198, directly inside small tumors under 2 centimeters, so it radiates the cancer from the inside out.
That's incredible. But then there is transoral laser microsurgery, or TLM, and here's where it gets really interesting. The notes pitch TLM as this incredible surgical alternative. You get precise resection with minimal collateral damage. It can even be a daycare procedure, meaning the patient goes home the very same day.
Sounds great on paper.
It sounds absolutely flawless until you see the specific, honestly terrifying disadvantage written in the margins. 2 words: airway fire.
Yeah, it is a profound literal risk.
I mean, you are dealing with a laser, a highly concentrated, intense beam of thermal energy cutting tissue inside a patient's airway, all while they are intubated and hooked up to a continuous flow of pure oxygen. It's like operating a blowtorch inside a fireworks factory. How can a surgeon possibly justify the risk of starting a literal fire inside a patient's throat?
The risk-reward matrix is definitely extreme, but it is dictated by the golden rule written right at the top of these protocols. Organ preservation is the first priority. If you use traditional open surgery on a tumor in the larynx, the surgeon often has to remove the entire voice box just to ensure perfectly clear margins. The patient survives, but they permanently lose their natural voice and their normal ability to swallow.
So the laser saves that.
Exactly. TLM, despite the harrowing risk of an oxygen fire, allows the surgeon to carve the cancer away with microscopic precision, saving those delicate vocal cords.
But preservation isn't always possible. If the cancer has invaded the bone or the tumor is just too large, the notes detail procedures like a mandibulectomy or a maxillectomy, which is the physical removal of large sections of the lower or upper jaw.
Right.
The cancer is successfully eradicated, yeah, but the patient is left with a massive physical void in their face. And this is where the deep dive leaves the battlefield and really enters the realm of human architecture. Phase 4, the rebuilders.
Head and neck reconstructive surgery is arguably the absolute pinnacle of surgical engineering, because when you remove a section of the jaw, you cannot simply stretch skin over the defect.
It wouldn't work.
Yeah. No, you must replace structural bone, functional muscle, and a reliable blood supply, or the tissue will simply rot away.
The notes dive really heavily into the mechanics of flaps. And before this, I always kind of assumed that skin graft and a flap were, interchangeable terms.
Yeah.
But the biological difference is massive.
A huge difference.
I look at it like relocating a fully grown potted tree.
Yep.
If you want to move a tree from your backyard to your front porch, you can't just hack off some branches and tape them to the porch railing. You have to dig up the entire root system, the soil, and physically plumb it into a new water line so it survives the transplant.
This raises an important question about how tissue actually survives trauma. A graft is just a piece of tissue moved without its blood supply, relying entirely on the new location to sort of slowly grow blood vessels into it.
Right.
A flap, however, brings its own life support system. The notes break them down quite nicely. A random flap relies on a random network of tiny, unnamed perforator vessels in the skin. But an axial flap is much more robust. It is harvested with a specific, known, named artery and vein to keep it alive.
And the undisputed heavyweight champion of this is the microvascular free flap, specifically the free fibular flap. When I read this, I genuinely had to read it twice. A surgeon cuts open a patient's lower leg, removes up to 25 centimeters of their fibula bone, along with the peroneal artery and the peroneal vein.
Yes.
They bring that entire package up to the head, literally bend the leg bone to mimic the curve of a jaw, and sew those leg vessels into the neck.
They are essentially harvesting spare parts to completely fabricate a new mandible.
But wait, I really have to push back here. If you remove 25 centimeters of structural bone from someone's leg to rebuild their face, I mean, doesn't their leg need that bone to function? How is the patient ever supposed to walk again?
This highlights the incredible anatomical redundancy built into the human body. We are remarkably over-engineered.
Really?
Yeah. The fibula is a smaller, non-weight-bearing bone in the lower leg. The thicker tibia actually handles almost all the mechanical stress of walking.
Oh, I didn't know that.
And the notes highlight a strict architectural rule surgeons must follow. They must leave at least 6 centimeters of the fibula intact at the ankle and 6 centimeters at the knee.
Okay.
As long as the structural integrity of those two joints is preserved, the patient will be able to bear weight and walk normally, entirely missing the middle section of that bone.
That is just phenomenal. And they apply the same logic to softer tissues, right?
Right.
Because the notes detail the radial forearm free flap, or RFFF.
Yes, instead of bone, they harvest pliable skin, tissue, and the radial artery directly from the patient's forearm. This is used to reconstruct the soft, flexible structures of the mouth, like a new tongue or the mucosal floor of the oral cavity.
But there's a massive catch detailed in the protocol, right? The Allen's test.
Oh.
Imagine you were the patient waking up. You just had your mouth reconstructed, but the doctors had to make sure the hand you write with wasn't going to lose its blood supply in the process.
Yeah.
Before a surgeon can borrow the radial artery from your arm, they have to perform this Allen's test on the other major artery in that wrist, the ulnar artery. They literally have to prove that the ulnar artery alone is strong enough to keep your hand alive.
The level of strategic foresight is just immense. And the final step of this reconstruction is where the tension really peaks.
Right.
Once the bone or tissue is moved to the face, the surgical team must operate under a high-powered microscope. They take the peroneal artery from the leg or that radial artery from the arm, and they must meticulously sew it to recipient vessel on the neck, typically the internal jugular vein or the facial artery.
These are tiny, right?
They are using sutures thinner than a human hair. If those microscopic stitches clot, or if the fluid dynamics fail for any reason, the transplanted tissue will die within hours.
So what does this all mean? We started this deep dive staring through a microscope at a few chaotic rogue cells desperately churning out keratin pearls. We tracked how those cells overflow the field, hijack the lymphatic highway, and forced doctors to hunt down necrotic security checkpoints. We explored the terrifying tightrope of firing precision lasers inside an oxygen-rich airway. And we ended with surgical teams harvesting the vessels and bones of a human leg to meticulously architect a new face.
It's unbelievable.
Reading these clinical notes fundamentally changes how you view the resilience of human biology. It is a profound testament to the sheer ingenuity of modern medicine.
It absolutely is. And to leave you with one final mind-bending detail from these sources that perfectly illustrates how bizarrely interconnected our biology really is, consider the Kyle leak.
The Kyle leak, what is that?
So during a complex neck dissection to remove those cancerous lymph nodes we talked about, a surgeon is working mere millimeters away from the thoracic duct, which is the main vessel for your lymphatic system. If that duct is accidentally nicked, a milky lymphatic fluid called chyle starts leaking directly into the surgical wound in the neck.
That sounds catastrophic. Do they immediately rush the patient back into the operating room to sew up the leak?
Not always. If it is a low output leak, the notes detail a completely non-surgical fix. Doctors can stop a surgical leak in the neck by altering how the patient's stomach processes fat.
Wait, you're saying they changed the patient's diet to fix a hole in their neck?
Exactly. Because the lymphatic system absorbs dietary fats directly from your gut. The protocol dictates putting the patient on a strict fat-free diet, utilizing medium-chain fatty acids or MCFs. Alternatively, they can administer a digestive hormone called somatostatin.
And that stops the leak.
By stopping normal fat digestion down in the stomach, they dramatically lower the fluid pressure inside the entire thoracic duct, all the way up in the neck. The reduced pressure allows the microscopic tear to simply dry up and heal on its own.
You bypass the stomach's fat absorption to patch a surgical wound in the throat. That is unbelievable.
It's all connected.
It brings this whole journey full circle. These notes aren't just clinical records. They are the ultimate architectural blueprint of the most complex interconnected machine on Earth. And learning how to read it, well, that's the ultimate deep dive.